Good evening. I'm Mike Knetter, and welcome to the UW Now Livestream series, where we bring you experts from the UW community to talk about various aspects of the COVID-19 crisis. The pandemic has tested many parts of our economy and society, but especially our healthcare system. Healthcare systems have had to prepare to manage extreme patient volume and develop and implement many new protective measures. Medical professionals and researchers have had to develop better treatments and vaccines in a real race against the virus to save lives. What have we learned over the past few months, and how will this knowledge help transform healthcare in the future? Tonight, we're joined by Dr. Robert Golden, Dean of the School of Medicine and Public Health, and Dr. Alan Kaplan, the CEO of UW Health. As is our tradition, each will give brief remarks, and then we'll take audience questions using the live chat feature. And I want to especially thank those who have joined us for the show tonight. We realize we're up against a lot of breaking news between a vice presidential pick, cancellation of some fall sports in certain conferences, and even a vaccine development in Russia. So we'll take some of those up this evening, but probably not all of them. Our first guest tonight is Dr. Alan Kaplan, the CEO of UW Health. Dr. Kaplan earned his medical degree from Rush University in Chicago, is a board certified in emergency medicine, and earned a master's in medical management from Carnegie Mellon. He's known nationally for leading large-scale clinical and cultural transformation with a focus on care coordination. Dr. Kaplan previously served as Executive Vice President and Chief Clinical Transformation Officer for UnityPoint Health, a multi-state integrated health system based in Iowa. He was the founder and CEO of UnityPoint Clinic, leading its 1,300 providers. He also served as CEO of UnityPoint at Home, a provider of home care, palliative, hospice, and home infusion services. Alan is a fellow of the American College of Healthcare Executives and a fellow and past board chair of the American Association of Physician Leadership. Alan, thanks for taking time out from what I know is an incredibly busy schedule right now to be here with us tonight and share a bit about your vision for the future of healthcare, particularly with emphasis on all that COVID has wrought for this critical sector of our society. Great to be with you, Alan.
Great. Thank you, Mike. And it's a pleasure to be here. And I just want to correct one thing you said. You said in my incredibly busy schedule, I just want to let you know all my social events have been canceled and I'm not traveling. So I have a little more time lately.
Fair enough.
A senior healthcare leader for 25 years. And what is probably the most profound observation over that 2.5 decades is that healthcare has not truly changed. The complaints I heard 25 years ago about long waiting times, difficulty getting appointments, dealing with insurance, and going through prior authorization, all these things existed back 25 years ago, and they still do today. Yeah, we have more technology, we have better treatments, but the healthcare system itself has not changed so much. And yet in a few short months, we've completely retooled our facilities, creating more ICUs, changing positive airflow rooms to negative airflow rooms, and making our facilities ready for a large influx of patients with COVID-19 infection. We've developed and implemented policies and procedures to keep providers, staff, and patients safe. We've secured personal protective equipment. We've developed testing capabilities. We developed new treatments, such as the infusion of convalescent serum. And we've developed, not us, but all of us developed a trained community that understands social distancing, wearing masks. Can you imagine if 6 months ago we told patients you can have one visitor, they have to wear a mask, you can't use the cafeteria, and by the way, we're the hospital of choice. So all that has changed in just a very short period of time. And I look at healthcare over the last 25 years, and I've never seen it change so fast. So society's been turned upside down, but I question, will healthcare really change going forward? I predict it will, and not because of the deep emotional state we're in right now and the threat of the pandemic, because the pandemic's going to go away. But I think there's three drivers that will change healthcare going forward. The first is consumer demand. And particularly, I'm going to focus on telehealth. So we own an insurance company called Quartz, a health plan. And we went from 2,800 telehealth visits in 2019 to 28,000 visits in April alone. And so what we're finding is that telehealth, which we always thought was for the young, technically savvy individuals with minor disease, is actually readily accepted by those who are aged, those with chronic disease. Can you imagine being 85 years old and having difficulty ambulating? You have to get up, get dressed, you got to drive to the hospital, go around the parking deck, find parking, find your way to the doctor's office, and go through the whole process for a short visit when you can sit in the convenience of your home on the telephone or computer, have a 15 to 30 minute visit, probably more time with your physician than you would had you gone to the clinic, get your questions answered, and have your chronic disease managed. It is by far a preferred way to receive care when care is appropriate for telehealth. And so we have this huge demand now by consumers for telehealth, and providers like it. Our physicians love it. And this is a time when 48% of all physicians across the United States are experiencing stress and burnout. Why would we not do things that make their lives easier? And then there's another consumer, and that's our employees. And as we implement work at home, we're finding a large proportion of our employees prefer the ability to work at home. The second thing that will create change is that some things you learn just can't be unlearned. So when I was a practicing emergency physician, if someone called me up and said, I have a fever and a cough and a runny nose, I would say to them, why don't you come on in and I'll take a look at you? Well, why did I do that? Why did all of us do that? All we did is say, come on in, infect all the other patients in the waiting room, the nurses and the doctors. And what we learned during COVID-19 is we separated our infectious patients from our non-infectious patients. We had drive-through testing centers. We screened people on the phone, did a telehealth visit, kept them out of the hospital. We're not going to be able to unlearn that because what we were doing before was just a bad practice. And the third thing that I believe will sustain change is a simple economic factor, in that hospitals have lost $200 billion collectively over the last 4 months and are predicted to have a total loss in calendar year 2020 of $300 billion. That is going to change healthcare. It's going to change what we can spend on facilities, technology, and invest in new programs. And indeed, UW Health is not immune from that financial impact. So as I think about what the future may look like, I have to first ask myself, what doesn't change? What's just not going to change? And if we look at the external environment, there's a simple fact that remains constant. And that is, at least the last time I checked, worldwide mortality remained a constant 100%. It hasn't changed. We are all going to die. We are all going to age. We are all going to be infirm. We are all going to die. And people want to live longer, and they want to live a more healthy, fulfilling life. And so that doesn't change. Healthcare is here to stay, and people need care. And people will age, and they will need resources that only we can deliver. The pandemic is estimated to increase cancer deaths by 10,000 over the next decade because of the delay in screening for breast and colon cancer alone. We need to be here to treat those patients, but be here today to encourage them to come in for screening as soon as possible. And when people get sick, they'll need the capabilities of our academic health system. where we do complex surgeries like transplant and pediatric heart procedures, where we provide multidisciplinary care, where we pool resources to take care of the most complex of illnesses, where we have access to clinical trials. This is unlikely to be a niche that will be filled by a Walgreens, a Walmart, or even telehealth provided by ourselves. So looking at all this and looking at the future, I also ask, what is the pandemic likely to change in our overall goals and strategies as a health system, as an academic health system? And the answer is, I believe, it won't. I think our goals are going to be the same. Our goals are remarkable healthcare. We are going to have strategies to make sure we improve our patient's experience, that we're very adept at delivering on clinical trials, that we are going to have smart growth, that we're going to have distinctive programs. What will change, and will change profoundly, is how we execute on those strategies. We will still create new programs, we will implement new technologies, we'll modernize facilities, but I think all this will look different. It'll be supplemented with digital health to a level we've not implemented before. We will change the way we flow patients for social distancing, to keep them safe, to keep our staff safe. That we will have virtual interactions in the offices so we can bring specialists into the patient room with the primary care physician. And we'll implement infection control procedures like we've never have before. I would leave with this last statement, is that I've been at this as I started for 25 years, and despite all sorts of threats to the way we deliver care, at least threats as a provider would see it, started with HMOs, it was retail clinics, it was physician-owned imaging centers and surgical centers, and it was one innovator after another. And what I would say is they didn't change healthcare, but a single strand of RNA is likely to change healthcare more effectively than did thousands of innovators and billions of dollars of private equity investment. I am now going to give it back to Mike, and I'll be interested in everyone's questions.
Well, that was a great setup, Alan. Thank you for that organized set of remarks and all the factors weighing on the industry. I'm sure that'll generate some great questions. Next up, we've got Robert Golden, who is the Robert Terrell Professor in Medical Leadership and Dean of the School of Medicine and Public Health. Bob also serves as Vice Chancellor for Medical Affairs at UW-Madison, chairs the board of UW Health, and holds an academic appointment in psychiatry. Prior to joining UW-Madison in 2006, Dr. Golden was the chair of the Department of Psychiatry at the University of North Carolina School of Medicine. And in addition to his role as department chair, he was the founding director of the Clinical Psychobiology Pharmacology Research Training Program. And he was also associate director of both the General and Mental Health Clinical Research Centers there. Dr. Golden is currently the longest serving dean at UW-Madison and one of the longest serving medical school deans in the nation, which leads many to wonder, how can he withstand all the pain? He received his BA from Yale University in psychology and his medical degree from Boston University. Bob, it is great to see you again. Of course, I jest about the pain. I know you love your job. You wouldn't have done it this long, and we're lucky to have you. I just wish we could stop meeting this way, but for now, we look forward to hearing your take on the future of medical education and healthcare more broadly. Thanks, Bob.
Thanks a lot, Mike. It's great to be back here. And I got to confess that when I got my assignment, which was to discuss the future of academic medicine, I've been a little nervous about this. I think that history tells us that predicting the future is very risky business. For example, if you go back to 1903, the president of the Michigan Savings Bank advised his attorney not to invest in this new startup called the Ford Motor Company. And he wrote, you know, the horse is here to stay, but the automobile is just a passing fad. Now, if you jump forward to December 2012, I excitedly announced to my family, we're going to the Rose Bowl, because I predict, of course, with Russell Wilson as the quarterback, there's no way Wisconsin isn't going to win the Rose Bowl. So with that as a caveat, I hope that you have a shaker of salt filled with lots of grains at your ready disposal as I share with you my predictions about the future. Academic medicine really refers to the two pillars of education and research, which are, of course, intertwined with the all-important clinical pillar as well. So I'm going to start with education. Now, we were already heading in a different direction, away from past tradition, years before COVID actually came. Traditionally, medical school was divided into two equal chunks: 2 years of sitting in a large auditorium, hearing lectures about basic science, the sage on the stage approach, followed by 2 years of intensive clinical hands-on training. We began a number of years ago to change that model in several really important ways. First, we switched the didactic teaching from large, boring lectures to small, active learning groups. We also condensed the basic science to 1.5 years, expanding the clinical part to 2.5 years and reintroducing basic science during the clinical years. We began literally in the first week having meaningful interactions with patients for our first-year medical students. And we also went to an integrated model of the clinical training. Instead of having silos where you would learn pediatrics for a little while, then learn medicine for a little while, we had integrated blocks for the medical disciplines and for the surgical disciplines. We also were an innovator in this country of having a statewide campus where our students could train not just at the Quaternary Care University Hospital in Madison, but in rural sites throughout the state and in small clinics throughout the state. And we think this gives a more broad-based training. Now, while there were many great strengths and advantages to this new model, which we fully launched starting about 4 or 5 years ago, there also were some vulnerabilities that became apparent because of COVID. So, for example, when COVID hit, there wasn't enough PPE to protect doctors and nurses in many of our training sites. So we had to pull the medical students off of those sites until it was safe for them to go back. We also had to immediately pivot from these small group active learning experiences in the first 1.5 years to an entirely virtual online curriculum. And to the remarkable credit of our educational team, that happened almost immediately. And that shift was really pretty incredible. And that, I think, holds promise as we talk about what's ahead in the future. So now our students are back in the clinical training sites, but we still have an uncertain future in predicting what's going to happen this year until COVID is really entirely under control. We hope it's going to go well, but it's possible with supply chain problems that there won't be enough PPE. We also know that the doctors and the nurses who are playing catch up with the pent-up need for the non-COVID care are sometimes so stressed and so busy that it's hard for them to really devote the time to teaching. So with that as a backdrop, where is the future going to be in medical student education? Well, building on what Alan said, I think we will see a dramatic increase in teleeducation, just as Alan described the increase in telehealth. And the two of those have to go together. We're also going to have to be nimble until COVID is really behind us and be prepared at a moment's notice to switch back to virtual learning. We also successfully teased out of those clinical years the didactic parts that were intertwined. And if worse comes to worse and there's a temporary disruption in hands-on clinical training, we'll have to go back to that. And because of the vulnerabilities of our wonderful statewide campus, we're going to have to increase capacity throughout the region so that we have extra capacity, not running so efficiently that if there is a bump and we aren't able to send our students to a particular site, we have other sites to fall back upon. So I think the present actually confirms our past decisions and points the way to the future. And I want to emphasize one important part of our past that is really defining us currently, and I think is where the future needs to go. About 14, 15 years ago, we began this radical experiment to become the first ever school of medicine and public health, combining those in all that we do, especially in our medical student education programs. Our peers around the country said, "Why are you doing that? Isn't it really difficult? Isn't it really expensive and complicated?" And the answer was yes, but we're doing it because that's where the future lies, in teaching our students how to prevent disease as well as how to treat it. And in understanding that the health of populations and public health interventions are really important. And boy, did COVID ever drive home that point. COVID is unfortunately a horrible way to really learn the importance of bringing together medicine and public health. And it's not just for COVID. I think that kind of integration is important for other kinds of important epidemics, whether it's opioid abuse, or whether it's high infant mortality rates in the African American population in the state. A combination of public health interventions promoting wellness, as well as a medical approach to diagnose and treat complications and diseases. That's where the real future lies. The rest of the country is just beginning to catch up. And right now there's 6, soon to be 8 other medical schools that are adopting our model, albeit in a lighter version than our full-in approach. So let's shift to the other academic mission, which is research. And it seems like a long time ago. If you go back to the year 2019 BC, and by BC I mean before COVID, we were a really strong research powerhouse, getting stronger all the time. But we did recognize that we had some vulnerabilities, some opportunities to be even better. For example, this campus really was an inefficient, complicated place to do clinical trials, whether they were industry-sponsored trials of new medications or investigator-initiated experiments. It was a difficult place because of the university and the school's bureaucracy. Also, we had not built in clinical research into everything that we do, with some exceptions. Our Carbone Cancer Center was a wonderful place that for many years has automatically offered its patients opportunities for clinical trials whenever it was appropriate. But there were other ways in which, other areas in which that wasn't the case. And certainly, like the rest of the country, as we were adopting the electronic health record, it was implemented in a way that was focused pretty much exclusively, understandably, on patient care, and was not fully utilized as a way of identifying clinical trials for patients who really need other options beyond what they have already tried and what hasn't worked out for them. So in partnership with Allen and with UW Health, the school and the university, before COVID, began to really address that. We invested in infrastructure. We hired a wonderful new chief of clinical research, Betsy Nugent, and we really began to push forward before COVID came in making this a desirable place for doing clinical trial research. Also, before COVID, there were a number of areas where we were national leaders in research and in clinical care. In addition to cancer, I would point to asthma, to Alzheimer's disease, and several others. Also, we had a wonderful strength in that this university is incredibly collaborative. And our research was made so much more innovative and strong because of our wonderful partnerships with the College of Engineering, with veterinary, pharmacy, and nursing, and with so many other units on campus. So with these strengths, we had good momentum and good headwind when all of a sudden COVID hit us. And it did throw us for a loop. For a short period of time, we had to completely shut down all of our research and then gradually build it back up once we were able to guarantee the safety of our investigators and their staff. Because of the strength going into it, we were able to hit the ground running, and in partnership with UW Health, immediately set up our own COVID testing, despite some limitations in what the federal government had to provide in that regard. We had on our campus, in our school, and in partnership with other schools, remarkable people, including our David O'Connor, David Beebe, who's both in our school and in the College of Engineering, and Tom Friedrich in the School of Veterinary Medicine. And they are continuing to innovate. And as we speak, they are developing potentially new, exciting, less expensive, more rapid testing that can be done on site, including on the campus and possibly in patients' homes. And it was because of our prior work in making us a better place to do clinical trials that we were able, right at the beginning, to get involved in some of the most important clinical trials. I hope you've heard about our groundbreaking participation in the plasmid, recovering plasma study that Alan alluded to. And as we speak, we are soon going to be announcing that we will be participating in one or two of, I think, the most promising vaccine trials. And it's really great that UW has been able to compete to be selected for these early vaccine trials. We also have been doing very important work looking at vulnerable populations. Amy Kine, for example, who studies zip codes and is able to come up with models to predict the most vulnerable segments of our state. Her work has been incredibly valuable to our State Department of Health and to policymakers in figuring out where to prioritize the interventions as we make difficult decisions about the COVID epidemic in our own state. We also have been doing important work in the interaction between cancer and COVID because of the strength of our Carbon Cancer Center. And looking into the future, unfortunately, I think we are going to have to begin to study interactions between COVID and cardiovascular disease, and COVID and how it affects other organ systems in the body. I hope that isn't the case, but early data suggests that it can really have long-lasting, devastating effects. And because of our integrated approach and our collaborative nature, I think we're ahead of the game. So here's my take on the future of research in the age of COVID. I think we must continue to make it so that we bake in to the clinical services and clinical facilities opportunities to make it easy for doctors and patients to discuss research opportunities that can help them go beyond what is the traditional approaches when the traditional approaches are not enough, and also help us develop the next generation of diagnostic and treatment approaches. Everybody. I'm really delighted that the leadership of UW Health in thinking about new facilities in another part of the town is baking into the facility and the program planning the incorporation of research and academics. And I think that's where the future really lies. The future also lies in expanding on our traditional strength in emerging pathogens. We need to do more on surveillance. We need to expand on our traditional strength in virology. We need to expand in the groundbreaking work that's going on in our campus now in discovering new antibiotics that are effective against bacteria and fungi that have developed resistance to current antibiotics. And we need to take that also more into the area of new antivirals as well. Most importantly, in the future, all of us have to advocate for more adequate funding for public health, both for research, but especially for public health services. It's a real sad story in this country that we don't give quite enough funding for medical research, but we give horribly less funding for public health. And while medical research needs to be brought up higher so that we can achieve our full potential, at the same time, we have to dramatically increase our country's investment in public health. And if anybody needs any convincing, just look at what's happening with COVID, where we were really caught flat-footed, especially from a public health perspective. Then finally, we have to do research on this campus, and much of this will be in wonderful units on the campus beyond our school, in effective messaging and communication. We have to know how we can immunize not only against COVID, but against the horrible mythologies, the anti-vaxxers, the folks that are anti-maskers, the people who somehow conflate good public health practice with political statements. And I am really upset by the truly bizarre conspiracy theories and myths that gain traction on the internet. And those loud, extraordinary, crazy voices have to be countered with effective messages, public health messaging. There's no reason why we can't all practice social distancing and wear masks. And there are many reasons why we must do that if we want to protect ourselves, our families, and our communities from the medical horrors of COVID, but also from the economic disasters that happen when we don't pay attention to those things. So that's, I think, really where the future lies. I do want to take just 1 minute to make one other point, a little bit off topic, but bear with me. Let's face it, we are all really, really exhausted. And I'm not just referring to your reaction to my ramblings in the last 10 minutes, but we're all tired of social distancing. We're all really tired of wearing masks, of washing our hands very frequently. But please understand that individually and collectively, we have to go the distance. We should not succumb to our fatigue and our frustration. In fact, we have to be prepared, if necessary, to really tighten up even more if that's what it takes to beat this virus. I'm constantly hearing from people who say, oh, enough is enough. Let's reopen the businesses and just sort of hope that things get back together. I'll leave you with the story of the guy who set out to swim across the English Channel, and he got 2/3 of the way across, and he decided he just wasn't going to make it. So he turned around and he swam back. If we give up now, if we, because of political or economic concerns, open up and give up on the important public health measures that Tony Fauci and everybody else talks all the time about on the news, if we give up now, it's like turning around after we made it 2/3 of the way across the English Channel. So please, let's all make a commitment to go the distance, and let's make sure we do what it takes. And I promise you that in turn, the School of Medicine and Public Health will do what it takes to guarantee a really bright future for the education of the next generation of clinicians and the advancement of better ways of preventing, diagnosing, and treating disease through academic medicine. Thanks. Look forward to your questions and comments.
Wow, that was a great statement, Bob. We will certainly be repackaging that, but really appreciate you saying that, spoken like a dean of a School of Medicine and Public Health. So thank you for saying that. You know, while we're on that subject, of course, there was other really big news today that we're competing with, or maybe not competing with, maybe we can comment on. You know, much to the chagrin of many Badger fans, the Big Ten and the Pac-12 decided to suspend fall sports this year. And, you know, there are a lot of people who wonder, gee, you know, these are young, healthy people. They could always opt out if they're concerned about it. And if they really wanted to play, why aren't we letting them play? As a medical expert, how would you answer that? What are the biggest factors that you think went into the medical aspects of that decision?
Well, let me say that I'm also really disappointed. I love Badger football. And in fact, came here because after 25 years at the University of North Carolina, it was time to go to a place with a real football team, okay? But this was absolutely the right decision from both a medical and a public health perspective. Number one, as a fan of football, I just can't understand how you can play the game wearing a mask and keeping 6 feet distance between all the players. So there's no way that we can keep those players safe, okay? There's no way that we can play the game without violating for the star athletes and their staff and their coaches, the principles that will keep them safe. Now, some people will say that most young people do not get as ill. Well, the key word there is most, and there are tragic stories of world-class marathon runners who died because of COVID, or who have had permanent, it appears to be permanent damage because of the ravages of COVID. So for the safety of the football team, we had to do that. But beyond that, we have to also think about the safety of the parents and the grandparents that the football players will then interact with. Even if they don't show signs of illness, especially if they don't show signs of illness, but they're infected, they will go visit with their friends, with their family, with their teachers who are bravely going to teach as much as they can in small class settings. So I really think it was the right thing to do. And then finally, as I was talking about messaging, Mike, it's really important to tell over and over again, all of our faculty, all of our staff, all of our students, you must follow the principles of public health. And so how can we expect that message to be credible if we say, you must do this unless you're a football player? Then you can go out there and violate all these principles and act as if that's okay. So I know this was a gut-wrenching decision. It's difficult for all of us fans, but it was absolutely the right thing to do. And let's just hope that we're in a place where we can enjoy spring football.
Great, thank you. Question from Brian Frona, and maybe Alan, you might take a shot at this, and Bob may want to chime in. How has or will the pandemic affect training for residents who are in hands-on specialties like surgical subspecialties or interventional radiology, where they have case performance requirements?
Yeah, so I'll start on this one. I'm sure Bob will have some follow-up comments. So Bob and I have always had a great relationship, and we've continued to strengthen the relationship between the health system and the School of Medicine and Public Health. We both know that we symbiotically live together, and the whole is greater than the individuals. And this is a great question in that regard, in that early in the pandemic, a lot of learners had to leave the hospital. Why? Because we didn't have enough personal protective equipment. It wasn't just, and it was, to protect the learners, the residents and medical students, but also to protect the patients. But we also had a burn rate on the supplies, and we needed them for our practicing physicians and our nurses. And so we had to excuse learners from the learning environment. So one of the things we learned is that we have to work together in teaching. We have to provide the supplies and equipment that we need to supply so that people can learn and learn safely. The other thing that we learned, and this is a little different, but on clinical trials, we can have great ideas, great researchers, great innovators, but to do clinical trials, we need the health system on board. We need the resources of the health system. We need the investment. We need the right environment to do these things. So I would say that throughout the pandemic, what was a good relationship always has just even tightened, because we realize how codependent we are on delivering great things to our patients in our communities. Bob?
Well, I completely agree. And I think the real key is that we need to protect all of our providers, including the faculty and the residents and the nurses and the clerks. We have to protect them. And that's why I think one of the most important lessons to be learned from this pandemic is that we shouldn't be so efficient that we don't have extra capacity, that we ought to spend a little money to have extra protective gear, maybe some extra space for overflow. And I think there is a distinction between residents and medical students, because medical students are learners who are there primarily to learn. They help a bit with clinical care, but we had a hierarchy where when there was a shortage of PPE, we pulled the medical students, but we had to keep the frontline troops, with oftentimes include the residents, active in order to not only enhance their training, but provide care for the patients.
Thank you, Bob. We might come back later on and talk a little bit. I understand that, the healthcare system maybe had run a bit too lean in this country. You were pointing out, maybe the thin margins that we had for bed capacity and such, and we might want to address that. But of course, that begs the question, how are we going to pay for that? The economics have become more difficult, and already people worry that our healthcare system's too expensive. So maybe we'll come back, talk about the efficiency gains that we might find. And one of those that's already come up is telemedicine. And Lou Blazek wonders, what are the parameters of billing when someone has a telehealth visit? And I guess I would say more generally, just what are the economics of telehealth versus an actual in-person visit? And can we increase maybe the level of care by doing more visits by going to telehealth? What are your thoughts on that?
Yeah, so there's a lot to say on this subject. And I'll start by saying that during the pandemic, about 190 federal and state regulations were lifted, and amongst them, many were in the areas of telehealth, which allowed us to deliver and bill for telehealth visits that weren't necessarily with pictures, so it could be on the telephone. That's important in rural areas without broadband. It's important with elderly individuals or non-elderly individuals without access to technology. And it was paying like a clinic visit with Medicare. The private insurers followed suit. So the first time we had payment that was universal, and so that created or helped create the explosion in telehealth visits. What I will say is that continuing with telehealth is dependent on the regulatory lifting to continue. If you were to ask me, was it enough to lift? If you were to ask me of the 190 lifted regulations, how many should remain? I'd say 380 of them. There's many more to go. But I will say economically, it is better for the insurance companies that will pay less for a telehealth visit than a live visit. And it's not as beneficial to the provider organization who will receive less for a televisit than they will for a live visit. So what we have to learn as a healthcare system is how to lower our cost structure. And we can do this. If we are doing more visits by telehealth, we need less exam rooms. We don't need as many waiting rooms. We don't need as many staff staffing those waiting rooms and cleaning our facilities. We can rid ourselves of some of our ownership of facilities and leases. So I think over time, what I think you'll see is this big peak in telehealth. I think it's going to come back a little bit. And as we learn to lower our cost structure, and as these regulatory changes become more permanent, I think you're going to see telehealth take off even more so than it is today.
Great. Thank you. You know, I alluded to the breaking news that we had going on all over the place today. I woke up this morning and learned that Russia had developed a vaccine and that it was already being administered. So, Bob, how do I get my hands on the Russia vaccine? Or do you think it's premature? And more seriously, who do you think the leaders are in vaccine development? Are there some that look to you like they're more promising?
Well, the road to new vaccine development is even more rocky and unpredictable than drug development. It's risky business. And instead of trying to get your hands on that Russian vaccine, I think we should run away from it as quickly as you can, because it is unconscionable that it's being given to people without any of the usual safety testing. You want a vaccine to not only be effective, but more importantly, it's got to be safe. And this is much more of an issue for even greater issue for vaccines than it is for new drug development. And, you know, our country is somewhat conservative when it comes to reviewing medications. In heroic, horrible circumstances like the early days of the AIDS epidemic and now the COVID, we loosen up a little bit, we fast track it a bit, but you don't want to be too loose. People of my generation might remember the thalidomide disaster, where in Europe, not in the United States, a new drug for pregnancy side effects was developed, and it led to a whole generation of babies born without limbs. And that's because it didn't undergo enough rigorous testing for safety and side effects before it was released on a wide scale. So there are a number of different promising approaches. And I don't think we can really predict which is the most promising, because there's the approach. Are you going for something that is going to largely stimulate antibodies, or do you go for something that's going to also provide coverage for another part of immunity called the T cell? So there's different approaches. There's also the difference of toxicities depending on the vagaries of the molecular structure of what you do. So I think this is a case sort of like throwing spaghetti on the wall. When you're in a real hurry, throw as much different new kinds of vaccines into development, carefully test them for safety before you go to wide-scale testing. And I don't think anybody can really predict, I don't think anybody should predict, which is going to be the front runner. And I'm really disappointed that some industry executives are prematurely making claims, even in this country, about their product before we really know how promising it's going to be for safety and efficacy. As I mentioned, we are, I can't say it publicly, but I will say without naming names, we fully expect any week now to make an announcement that we will be participating in one of the very, very promising vaccines in terms of its approach. And we also believe that we will be shortly afterwards given the opportunity to participate in another one. And I hope that people will step up and agree to participate in those clinical trials so that we can really cross the finish line. I also want to say that while vaccines are incredibly important, they are not going to be a magic bullet. If you think about the flu vaccine, it doesn't convey 100% immunity, and it doesn't convey permanent immunity because the virus can outsmart it year to year. I'd be surprised if that isn't also the case for COVID. But if it's 70, 80% effective, and if most of the eligible people agree to take it and are not swayed by the lunatic fringe that comes up with all sorts of claims that are really patently absurd, it can dampen down the infection enough that hopefully with some effective treatments, we can really suppress it and then keep it suppressed with ongoing vigilance.
Thank you. We'll look forward to those trials that we're going to do here. That'll be exciting. Question from Apurva Dhawan: how is UW Health and the School of Medicine and Public Health addressing the racial disparities in COVID outcomes, and more broadly, the impact of systemic racism in health outcomes generally?
Yeah, so this is a really good question. And 2020 has been a fascinating year. We started with a pandemic, then financial calamity. Then I turned 60 years old, couldn't have a birthday party. And then we had the death by police and the protests. And what that did was start to just heighten the awareness of the systemic racism that's been present within our society for a long time. And as a leader of a health system who delivers care to patients, who tries to improve the health of communities, that has 17,000 employees, that's a member of the community, we have a responsibility to dismantling racism. And so it's interesting the timing at which it came to be, but it's here. And certainly COVID-19 also helped bring this out, the social determinants of health, as we saw communities of color more heavily impacted for a variety of reasons and higher death rates. And so as a CEO right now, I need to deal with the pandemic. I need to deal with the financial calamity, and I must address systemic racism. And so we initially, like every other company, put out a statement that how we felt and how we were anti-racist, but we didn't feel that was enough. And so we put together a 4-part action plan that we brought to our board of directors for approval. We put resources behind it, and we are intend as an organization to actively engage in a strategic plan to address systemic racism, both as regards to our patients, within our employee base, and into the community, and in any sort of advocacy that addresses social determinants of health. And we also believe that there'll be a time when the pandemic goes away, but we don't believe our role in dismantling racism will go away. That will be persistent, and I believe something that we always have to focus on throughout the rest of my career.
Bob, any thoughts from the medical school perspective on education and maybe training the next generation?
Yes, dealing with racism and social disparities is one of the top priorities for the School of Medicine and Public Health in all of our missions. Through our Wisconsin Partnership Program endowment, we are investing millions of dollars in community intervention projects that are brought to us as ideas from the community. And we, when asked, will provide academic partners to help support the evaluation, but we are supporting in all counties intervention programs aimed at health disparities. Also, we, for a number of years, have had a program, the Centennial Scholars Program, designed to put additional resources into recruiting more diverse faculty. It's been very successful, and we're now going to double it with a parallel program for clinicians, the Centennial Clinicians Program as well. On the medical student side, going back a number of years, we defined medical student scholarships as a way of increasing the diversity of our medical student class as one of our top fundraising priorities. It's been very successful, and this year I'm proud to say we have the most diverse class of medical students in the 110-year history of the School of Medicine and Public Health. And then finally, baked into the curriculum for our medical students are areas of emphasis on racism as a public health crisis, ways of advocating for public policy that will begin to address racism in society and in healthcare systems. And inspired as Alan was by the events with George Floyd and other horrible events, we are now engaging one of our faculty, who is an NIH-funded investigator in this area, to create curriculum for the faculty so that our faculty of color can get evidence-based training on how to successfully navigate some of the challenges they experience with patients that sometimes display racist attitudes to their providers. And also a curriculum for those of us who are of white majority and learning how we can be more effective as effective intervening rather than passive bystanders when we witness experiences directed towards our peers or to our learners or to our patients, how we can effectively try to mitigate the negative impact of systemic racism in our society. So this is one of our very top priorities, and I know that, like other important public health imperatives, it's going to be a marathon, not a sprint, and we're going to be in it for the long game.
Well, thank you both. Can I ask, what are some of the top takeaways that we have to this point on treating the virus? What are the most effective treatments? What have we learned? And do you think the fatality rates are going to go down because of the greater efficacy of various treatments?
So it's a complicated question. So we have developed new therapies like convalescent serum infusions. We're looking at remdesivir. We'll be looking at other agents. But some of the advances that have been most impactful are little things like not intubating a patient and putting them on a respirator too early. Just some of the very simple things we do to take care of patients more effectively is some of the learning. So we have that, and we've also learned how to keep our caregivers safe in that environment. So I think it's the simple things that have had the most impact so far. But I think some of the developments, like the ones I just mentioned, are going to prove to be effective, especially the serum. I believe that will truly be effective. And early indications are that it's so. And of course, what we all need is the vaccines.
Yeah, and let me add that we've learned how much we still have to learn about this really unique and horrible virus. So, for example, sometimes the body's immune response to fight the virus does more damage than the virus itself. There's what we call an inflammatory or cytokine storm that can actually cause fibrosis in the lungs. Sort of analogous to an autoimmune disease, only it's not immune against the self. It's immune triggered by the virus that then attacks the self. And so for some patients, ironically enough, immunosuppression is helpful in preventing the body from damaging itself as it tries to fight the virus. The key is, you don't want to go immunosuppressing people who need their immune system to fight the virus. And so I think the future of research also includes, through a biobank that we are supporting, getting tissue, getting virus genomic analysis and getting patient genomic analysis. And over time, we hope that we can do personalized medicine. So based on the particular strain of the virus and the particular genomic heritage of the patient, we can identify, I hope in advance, those patients who are at risk for the cytokine storm and would benefit from immunosuppression versus those patients where we do not want to suppress. If anything, we want to enhance their immune response.
Great, thank you. Changing gears a little bit, question from Hannah Barton. What do you see as the role of engineers in the future of healthcare delivery and medical education? You had referenced earlier, Bob, some of the great partnerships that we have here at UW and the collaboration, but specifically, do you see engineers playing a bigger role in the future?
Oh, they're playing a huge role in the present. I want to think where we would be without our College of Engineering and their collaboration with us and with their department in the state. Everything from quickly designing and manufacturing fairly inexpensive shields that make it safer for not only our doctors and nurses, but for our professors when they go back into the classroom. And what they've done is just heroic. They also, through these amazing technologies, were able to quickly manufacture certain parts of our respirators back when we thought that we needed to use them more than we now realize, so that we could convert other kinds of equipment to service as de facto respirators. In terms of sort of systems engineering, before COVID, we were using them very, very often in the health system and in the school to help us design more effective ways, more patient-oriented ways to have a smoother flow from when the patient walks into the clinic to when they actually receive the interaction with the doctor that they need. And so I think that we are blessed with having a world-class College of Engineering where they are really, like the rest of the campus, really engaged in collaboration. There are absolutely no silos. We have faculty from the College of Engineering who have their laboratories in our school space, and we have our faculty who work with the resources in the College of Engineering, and that's what makes this a really special place. So the present and the future will depend more and more on not just traditional biomedical engineering, but also systems engineering and other kinds of technologies that can help with drug delivery and with everything from processing the patient to micro technologies for processing drug delivery.
Great, thank you. Question from Rafael de la Vega. How do you think clinical research needs to change, and which technology gaps have become evident that are needed to be addressed to be better prepared for future pandemics specifically?
Well, that's a great question. We've known that there are real challenges that as we have the potential to have huge data sets, combining laboratory-based information about the human genome with information from a population base in order to store and process and analyze that data, the technology needs are enormous, both in complexity and in cost. And there's also a difficult balancing act. Above everything, we have to protect the privacy and the safety of our patient data. And that can be a challenge when we want to share that data with people outside of the field of medicine. And there are ways to do that safely in terms of de-identifying it, but every step adds to the complexity of the technological capacity you need to take the data, cleanse it, use it, and then bring it back so that it can be interpreted at the patient and the population level. So we again are blessed in this campus that the campus is making large investments in information science throughout the campus. UW Health, in partnership with the school, is also making investments. And we have to build the bridges so that the electronic health record data can be safely and privately combined with what's happening in our basic science laboratories looking at the human genome.
Thank you, Bob. And thank you, Alan, for being here with us tonight. Really appreciate you taking the time. What everyone else doesn't know, but what we know, is this was kind of our teaser introduction to what's to come, which is the Wisconsin Medicine live stream series, which will kick off next week, Tuesday, August 18th at 7 p.m. The theme next week will be Taking Down Cancer with Tech, and we look forward to a great show. Our regular UW Now live stream series addressing the various aspects of COVID will rotate every other Tuesday with the Wisconsin Medicine live stream. So I want to thank both of you for kind of being the gateway drug to that series tonight. It was great to have you here, and we'll look forward to sharing the stage with you. Everyone is very excited about Wisconsin Medicine, and you've played a fantastic role in the community and beyond. So I want to thank you for that, and thank our audience for being with us on what is an otherwise very heavy news day. So thanks everyone for joining us. Great to be with you again tonight, and on Wisconsin.